Sorry, I might have missed this, but I don't think we have met. You- can you let us know where you are, what you do too? Um,
Hi, I'm Sayer. I'm currently in Germany and I'm waiting for my match results and I'm subscribing for the first time. I'm excited for the session
Thanks for your help and best of luck with the match.
and thank you.
What field are
All
you going
right.
into, Sire?
I have applied in internal medicine and family medicine. Yeah,
Fantastic.
yeah,
Excited for you.
yeah. Thank you.
All right. Let's get underway.
So, Sire, if you just want to share screen. If there's technical issues, I don't know, Julia, if you want to.
Yeah. I will share my screen. Just a sec.
Okay, awesome. Thanks so much. All right, we're in business. Take it away, Aishwarya.
Yeah, sure. So I have seven aliquots to be shared here today, and I'll be starting with my first one. So I have here a 74-year-old gentleman with smoldering multiple myeloma who's brought to the emergency department by the EMS for an acute altered mental status for 1 day associated with decreased level of consciousness. Um, that's my first aliquot.
Zaven, you want to kick things off? Then I'll tag on.
Sure. You're our altered mental status expert, but happy to share some initial thoughts. So what we've heard in terms of the background of our patient is that he is elderly and that he has this condition, smoldering multiple myeloma, which is it's an interesting adjective to attach to a disease, isn't it? So there is a plasma cell neoplasm in this patient um, with kind of abnormal proliferation of plasma cells and potentially secretion of kind of abnormal immunoglobulins, potentially kind of dysfunction of the immune system related to that. But that is not yet causing end organ manifestations in the form of, bone marrow dysfunction and anemia, in the form of bone lesions and pain or fractures, in the form of kidney manifestations and injury, or in the form of hypercalcemia or others. But it's there, and there's um, a pretty significant risk of progression of this disease to um, uh, myeloma, kind of more clinically, symptomatically significant multiple myeloma. And what he's coming in with is an altered level of consciousness, a reduced level of consciousness, um, which is one of the more kind of basic neurologic functions is just to be awake, right, and to be aware. Um, I think it's a different situation when you can't wake somebody up compared with when they're looking at you and talking to you, and their brain is just not quite able to grasp um, more advanced kind of concepts of cognition, of awareness, of time and place, and things like that, of thinking more linearly. So whenever there's a reduced level of consciousness, there's a couple of things that you want to make sure you're not missing. Um, with, before you have more information, before you spend time, and those things are a reduced level of consciousness because of hypercarbia, which can kind of progress rapidly and is sort of a metabolic situation that may not be very sustainable. So that's one thing to consider. The other is whether there's potentially related to that or not, an excess exposure to opioids that are both CNS and respiratory suppressants. And the other is sort of profound hypoglycemia that, again, could be acutely life-threatening, acutely reversible. So I think those are three kind of no-miss early things that should cross your mind, and you can kind of like rule out while you're gathering other information. And then finally, sort of this is quickly apparent on examination and vital signs too, is just sort of non-perfusion of the brain because of systemic arterial hypotension. And again, that's another thing that I would very quickly want to know. My best guess is that it's not necessarily those things, and we might quickly hear a story that paints a different picture, but those are kind of no miss emergent kind of rule out conditions before we get too much farther into it. And then of course there's a million other things that could suppress brain function and level of consciousness, hemodynamic, metabolic, non-specific infection related that we could characterize as sort of hypoactive delirium from whatever. But that's where I'll stop for now.
Nothing to add. That was awesome. Let's hear some more, Aishwarya.
Thank you for those points. Coming to the HPI, for his wife, he has had difficulty balancing prior day, and on the morning of presentation, he could not respond to voice or speak. The patient groaned with movement and appeared uncomfortable. And at baseline, his functionality was he was independent within his ADLs. Wife did not mention any headache, neck stiffness, nausea, vomiting, chest pain, focal weakness, or vision changes. She reported fever for 2 days, which was not associated with chills or rigors, and there was no prior head trauma or fall. No new meds or dosage changes to his medications. And he has had no change in bowel or bladder. Coming to his past medical history, he's known to have hypertension, heart failure with reduced ejection fraction, atrial fibrillation, hyperlipidemia, smoldering myeloma, more than 20% blast cells biopsy proven, and asymptomatic, stage 3A CKD. Coming to his medication history, he's currently on amiodarone, atorvastatin, and carvedilol. He's not on any therapy for his multiple myeloma because he's also asymptomatic. And his family history, personal history, and social history were negative. So that's been the history so far.
Thank you. Aishwarya, a lot to work with. And I'll just say, I think painting the picture of him really only, waking up with grunting makes us even more worried and extremely paramount, right? To quickly identify and treat those sort of five very dangerous things that Zaven mentioned, right? Hypotension, hypoglycemia, hypercarbia, brain catastrophe, or what was the other one that we're missing? A med toxin. Because he's not waking up, right? And we're really in the category, as Zaven was emphasizing, of altered level of consciousness, meaning he's not awake and alert in front of us. That means something pretty severe is going on versus being awake and alert and just having abnormal thought content, which is confusion. So we heard from the beginning, we're in the altered level of consciousness kind of category, and we really are quite worried about this gentleman. I think there are already some great thoughts in the chat about how his myeloma, which impairs his humoral immunity, predisposes him to infections, even without being on treatments. So I'll just shout out some of the great thoughts Sam had on there, particularly some of those infections that can have more of an acute onset as opposed to smoldering. And then the balance issues being one of the first neurologic signs that he had is really interesting. Doesn't help us narrow it down much because when it comes to the basic neurologic functions required to keep your balance, you have to be able to see what's in front of you, sense what's on the ground in front of you, and also have the vestibular function to put it together. So there's many different parts of the neurologic system that can be impacted, kind of vision, sensory proprioception, vestibular kind of connections as well. So we'll have to see kind of how that layers on with where this process is happening. But the acute fevers make it really worrisome. I think really prioritizing infection over other non-infectious inflammatory etiologies and wanting to move ahead pretty quickly to make sure there's not a kind of lesion in the brain. And I think we'll be thinking potentially early on about whether the sorts of the fevers could be primary CNS versus something systemic, as Zaven said, which of course could make anybody who's older and has an underlying comorbidity sick as well. I'm looking in chat at, I don't see any kind of particular signals one way or the other in the meds or the medical history otherwise to help us favor particular etiologies for why he might be confused. But I think what we get with this aliquot is a sense of urgency. As we've said in many of these sessions that Robbie says, right? The quicker these symptoms came on, the quicker that we need to find them. And very worrisome how quickly this guy really became non-responsive. And I think with the acute fevers and the acute balance issue, we're going to be laying on potentially an infectious etiology that's having a primary neurologic disturbance. Anything you want to add on, Zaven?
No, that was great. I just want to shout out something else from the chat too. Seema shared the mnemonic SCAN for sugar, CT, ABG narcotics for that kind of
Ooh,
like
love that.
first pass of reduced level of consciousness. Yeah, that's great. And we can get the next aliquot, Ashwari.
Sure. So coming to his vitals on arrival, his temperature was 99.7 with a tachycardia of 110, and he was tachypneic with a respiratory rate going up to 36. He was also hypertensive with a BP of 176 by 94, and his SpO2 was 94%. His physical exam showed he was awake, but he was alert to self only and unable to follow commands, agitated with moderate distress. His neurocheck showed he could open eyes spontaneously, move all extremities, and does not follow commands or answers questions. His GCS was around 9 out of 15. There was no nuchal rigidity. There was slurred speech with a subtle right-sided gaze preference. And coming to his systemic exam, his lung showed tachypnea with clear lung sounds and no adventitious sounds. His heart exam showed tachycardia with no murmurs. And there was no focal trauma or any rash present on physical exam. Rest of the exam was pretty much normal.
Thanks, Aishwarya. I agree with Lara, by the way, that you have a very clear, easy to follow a way of communicating clinical information that is just really helpful in helping to think about the patient. So thank you. And I guess I want to share how I think about when there's a syndrome of suspected infection, like I think all of us would agree we're seeing signs of, right? The historical fevers, the abnormal temperature on the current exam, and then very much kind of signs of systemic inflammation in a way of tachycardia and tachypnea. So when there's suspected infection and then the brain doesn't seem to be working well, how do we think about whether this is an extra, a sort of an intrinsic, an extrinsic process outside of the brain that is just sort of toxic metabolically poisoning the brain, or if it's an infection that could actually be involving the brain directly, it's in or around the brain, and whether to prioritize, brain imaging, whether to prioritize lumbar puncture, um, to, to diagnose that, and obviously it might inform different treatment. And I think there's a couple of things that I think are helpful. One is your assumed level of baseline brain function. So if somebody has a just a pneumonia, and it's a severe pneumonia, it's causing sepsis, they're sick, but they're 30 years old and their brain is sort of very healthy and resilient at baseline. Most patients like that would not become confused or sort of overtly encephalopathic. By contrast, if it's someone of more advanced age or has a baseline um, uh, brain abnormality, dementia, cognitive dysfunction, whatever, um, or just sort of systemically is more frail, that person would be more likely to potentially have kind of severe, profound encephalopathy. And sometimes, again, the hypoactive version of that can sometimes even affect level of consciousness significantly, where the person can be difficult to arouse even. Um, and that would be much more likely. And again, you wouldn't as much tend to invoke a potential direct involvement of the CNS of the infection. And then the other thing that we're kind of potentially seeing here a little bit is a potential focality of the neurologic exam. Now, slurred speech isn't necessarily a kind of a focal neurologic finding, although it could be, right? It could occur from motor dysfunction or coordination dysfunction in the sort of nuanced physical task of articulation that takes a lot of strength of certain parts of the tongue, of the lips, of the pharynx. But it could also be you see it very commonly in a toxic metabolic context. Take, for example, someone under the influence of ethanol, right? Um, the so that's a little non-specific. The right gaze preference, though, I think that would, by the way, kudos for kind of catching that abnormality. That could, and I'm not sure. Could you clarify, Shwarya? Does that mean like a deviation of the eyes rightward, or is that there's a sort of potential subtle hemi-neglect that is being noted?
It was deviation,
Eye
like
deviation.
yeah.
Okay. So, yeah, that's a bit unusual. I think I mean, it could have to do with neglect if the gaze preference or like looking a certain way is intentional in that I'm sort of attending to things on the right side of my body in the universe. But it could also be sort of localized to a different part of the brain, not the parietal lobe that sort of determines attention, but rather potentially an overactivity of one frontal lobe where the frontal eye fields are that direct kind of gaze deviation, conjugate gaze deviation, or an underactivity or an insult to the contralateral frontal lobe, contralateral frontal eye fields. So if you see anything that could be focal neurology, again, your suspicion for potentially a process intrinsic to the brain, of course, goes up significantly. But it's not perfect either. And this is once again where the baseline neurologic function of the patient comes in, where if the patient has an old stroke where there was a focal insult to the brain, even if that insult sort of was removed and the brain healed and the neurologic function went back to normal now there's this sort of like dip, right? Where we're getting by, everything's above the clinical threshold. And when there's a diffuse process of sepsis or hyponatremia or hypoglycemia, everything dips together and the part that was low now crosses the threshold of dysfunction. And that's what we refer to as sort of recrudescence of old symptoms. So again, I think we're getting, this could all just be pneumonia, which again, people with myeloma are very high risk for sort of infection with pneumococcus and other encapsulated organisms. This could all be pneumonia, but we're getting some signals that there could be something central to the CNS, either around the brain, answered with an LP, or in a form of sort of embolic disease and endocarditis or a brain abscess, something like that, where we'd have to take a look with cross-sectional imaging. And I think there's already enough that I would want to see the patient's brain, I think. But certainly the even easier, quicker to get tests might start to point us in one direction versus another too. Sorry, I've rambled a little bit and I haven't been looking at the chat. Steph, please add or highlight anything else that other folks contributed to the thinking.
Just totally agree, right? Whether it's new or old, there's a localizing sign in exam. The threshold for head CT has completely been met, right? And maybe even with global encephalopathy, without focalizing signs, we would have wanted to do that anyway, but we're very much worried about an anatomic lesion now. There was some good discussion about particularly the hypertension and the significance of that. We're relieved it's not low and that this isn't malperfusion. Is it his baseline hypertension versus reactive catecholamine surge to what's making him sick has been a good part of the discussion there. Excited to hear more, Aishwarya.
That was a great discussion. Coming to the labs, so on his initial labs, his lactate was found to be 4.6, and on redoing the lactate, it was later found to be 5.3. His procalcitonin was 30.4, and he was found to have anion gap metabolic acidosis with a HCO3 of 18.5. Then his creat showed AKI with a creat of 6.25, with his baseline ranging from around 1.2 to 1.5. And his urea nitrogen was 125, and his CK was around 401. His CBC showed no leukocytosis, and his hemoglobin was normal. I don't have the numbers currently with me, but then his calcium turned out to be normal, and albumin levels were normal. Those are the labs for aliquot 4.
Okay. I think, the first lab that you mentioned, Aishwarya, the lactate, commonly, right, something we get early in people who are sick. And sometimes the framework is thinking about kind of hypoperfusive, either global or local etiologies versus not, which is the framework of type A, type B lactic acidosis. But it was interesting at the Society of Hospital Medicine a couple years ago. Tony Brew, who many of you know, runs the Things We Do for No Reason and is a great med educator in Boston, really opened up a whole new framework that I thought was very interesting. I can screen share in a bit if helpful, but really just thinking about what does it take to turn glucose into ATP and thinking about what things can break down that cycle. So one reason in sepsis lactate goes up is purely the beta-2 activation, the epinephrine that's surging, increasing glucose production to pyruvate. Point being, I think in many infectious causes, we see lactate without this hypoperfusion in the background, which is the case here. And it can just mean someone's sick and has adrenergic drive. I think for this gentleman with mental status changes, we haven't heard a lot about his nutritional history, particularly with the lactate sort of not getting better quickly with early resuscitation, wondering about could there be underlying thiamine deficiency? Does he have underlying liver disease? Or is it a manifestation of just sepsis in general? So what do I mean to say? I think don't panic when the lactate doesn't go away immediately on recheck. A lot of just the underlying adrenergic drive can be driving that, as well as some of the background conditions that I mentioned. And you still just want to make sure that you're treating the patient and moving forward, even without improvement in that lab parameter. I think the creatinine elevation to 6, the question becomes, is that effect of him being sick or related to the primary syndrome? He's only been sick a day, and we did hear he had CKD, but he's dramatically above his baseline. So has he been not eating and drinking long enough for the creatinine to be that elevated? Or again, is this sort of unifying the fact that he's been ill from something for a little while? I think is a question that I have out there. Um, the procalcitonin being that high, if it's what are the units, Aishwarya? Just want to make sure because for the units I'm used to, that's incredibly high, and I want to make sure.
Sure. It's 30.4 nanogram per milliliter.
And what's the upper limit of normal? Do you know?
Um, I don't have the one with this lab right now, but
I think, Steph, I think it's all the same units, and this is
It's
an
all the
extremely
same
high
units. I was just
value.
checking. Yeah,
Yeah,
we use
yeah.
nanograms per milliliter. So it's incredibly high procalcitonin. I think not directly diagnostic of sort of bacterial, but really enriches our worry about bacterial infection, systemic severe infection in this gentleman. Again, and a host who's at risk because of that smoldering myeloma and humoral mediated problems with immunity. So, kind of what we're left with here with the labs, like we knew he was sick, he certainly is. Right, something is driving kind of lactate elevation that isn't from, right, hypotensive sepsis at this time, probably enriched for a bacterial source, which is just such an important data point because if we had any question about early antibacterials for this guy, that's been put to rest based on some of these lab datas. And then I just don't know what to do in terms of sort of the creatinine. It's a big, big trend from before, but the timeline of that is sort of missing and not sure how to piece that together. What would you add, Zaven?
Not much. I just you reminded me, Steph, of I forget who this was, but a nephrologist who taught us in residency. I remember there being a case conference and him making this point that anytime you see big time AKI with what seems to be small time hemodynamic insults,
Mm,
to consider renal artery stenosis, kind of makes sense, and then multiple myeloma, and just emphasizing that the effects of myeloma on the kidney are myriad and have a lot of different functions, but there is this sort of susceptibility to kind of acute on chronic kidney injury when there's involvement. So it might kind of make sense in that way because I think just based on the hemodynamics, I mean, sepsis can cause kidney injury in a lot of different ways, and it's not just through hypotension, right? And actually connecting to the same point you were making, Steph, of like the metabolic dysfunction of not being able to use oxygen, and uh, kind of as reflected in the lactate, as reflected in some patients with sepsis and having like high mixed venous O2 sats, where like that's sort of an objective measure that like the tissues aren't extracting oxygen from the blood, right? And so it could make sense in that way, but yeah, I think I think the key is to figure out where this infection is, to think about what the likely microbiology might be, and to start empiric antibiotics. Because that seems to be the process, and it's important to sort of initiate appropriate antibiotics, and it's time sensitive. Yeah. Aishwarya, do you want to go ahead with number 5?
yeah. So, coming to the imaging, we did a CT head, which was found to have no acute intracranial abnormalities. And then we went ahead and we did a CTA head and neck, which showed no LVO or aneurysms or any significant stenosis. The chest X-ray showed prominent cardiac silhouette and hypoventilatory changes. His urine analysis showed cloudy urine with large leukocyte esterase in moderate blood. WBC in the urine was 180 per HPF, and RBCs were around 19 per HPF with moderate bacteria.
This is urosepsis. Statistically, again, we're in VMR. Maybe it's not, but I mean, I think this so far this is a very common presentation of sepsis with encephalopathy, with AKI, with lactic acidosis, circulatory metabolic dysfunction. And the data we have thus far is pointing to the urine as the source. I would guess and bet that, again, at least 6 to 7 out of 10 such patients would, the lab will call you in the next couple of hours saying that the blood is growing some gram-negative rod. And yeah, I think that would be my working diagnosis for now. I think just to kind of shift towards sort of treatment decision making, this is where I think just knowing your local antibiotic susceptibility patterns is really important. And this is a patient in whom we don't have a huge margin of error of not covering the bacterium that is most likely kind of causing this illness. So if this patient was a little less sick or a little less frail at baseline and susceptible to overwhelming infections, you might be okay, just starting treatment with ceftriaxone. But at some of our hospitals, the rate of ESBL positivity among E. coli is 30%. So it would be very reasonable actually to not take that chance and to have the first dose of antibiotic that this patient receives be a carbapenem. Similarly, there's significant pyuria. That's a very common source of infection, obviously. And this patient doesn't have indwelling lines or other things that we could kind of quickly suspect might cause chronic significant like sterile pyuria. So, but again, we're not 100% sure that this is a UTI. It could be another source of infection, a primary bacteremia with a gram-positive, a pneumonia that the chest X-ray didn't show that's actually staph or something else. So I also would include a good gram-positive MRSA and enterococcal, common cause of UTI in older men too, coverage in the form of vancomycin in addition to the gram-negative coverage. So yeah, I think that's what I'm thinking at this point. And I would also, make sure to talk to the family and make sure that they understand that, her husband is very sick. We're going to do our best to treat what we think is an infection and hope that he recovers, but to make sure that they're not too surprised if things continue to worsen, because again, it wouldn't be too surprising. Steph,
I like the point you made, Zaben, keeping in mind, right, the limited sensitivity of some of the radiology we have. So I think I completely agree. We're worried about potential urinary source with bacteremia and covering that. And then I think that's fine, right? See how he does, but we'll recognize, chest X-ray is only 50% sensitive in ICU patients, for example, to pick up pneumonia. And of course, the limitations of brain if the initial CT was non-contrast of the head. But we've got a potential source that makes sense. And I think starting with that and seeing if his mental status improves is, I think, realistically what a lot of us would do. Excited to hear more.
Can I just say one more thing, which is like,
Yeah.
now that we have this sort of like signal in the UA, and again, I think I trust Aishwarya would have told us or sort of did this to begin with, but depending on how well I had examined this patient the first time around, specifically their abdomen and their back and their flanks and their bladder, I would go back and examine them again to see, since they are awake, even though they're confused, to see if it obviously hurts to push on their bladder, or if it obviously hurts to push to tap on their flanks over their kidneys, right? And that would further strengthen this suspicion. But to also be aware that the infection could actually be from another intra-abdominal source. And it's not uncommon to have, kind of peritonitis or almost peritonitis from a hepatobiliary source or an enteric source that is inflaming the bladder from outside in and causing sterile pyuria just because there's inflammation outside the bladder wall. but it's not a urinary tract infection. So if this person was, for example, not tender over the kidneys or the bladder, but very tender over the right upper quadrant, I would definitely want to image the abdomen to see if there's, perforated gallbladder and cholecystitis, or gnarly diverticulitis, or something else, sort of that would require abdominal imaging and potentially a different treatment in addition to what we were thinking.
Thank you for those inputs. That was added a new perspective to this case. Uh, I think the examination that we did, I think it was repeated and we didn't find any abdominal symptoms. So, yeah, that was a surprise. So coming to the Aliquot 6, given his altered mental status and considering the SIRS criteria, sepsis protocol was initiated and ceftriaxone was started. He was given fluids cautiously given his heart failure history, and the neurology felt that the presentation favored a toxic metabolic encephalopathy, and the stroke order set was discontinued, and the nephrology was consulted for the uremia and the AKI. Hemodialysis was initiated, and there was no change of his mentation. On day 4, the nursing witnessed a 4-minute seizure characterized by head and neck high frequency jerking with eye rolling, followed by a post-ictal state. Post this, his microbiology blood cultures came in, and the blood culture showed strep pneumo in 2 out of 2 bottles, and his urine culture grew Serratia mercensis. So that's Alport 6.
The plot thickens. There had to be a twist, right?
So he did have a urinary tract infection, but there's strep pneumo in there also. Again, back to the point that everyone identified from the beginning with the myeloma. This patient is very at risk for strep pneumo, so the organism makes a lot of sense. And here we have what was a very reasonable first, attempt at making him better, treating the sepsis, what we thought was urinary source, getting rid of the uremic encephalopathy, and yet he ends up, right, having a fever and having a seizure rather, and having an additional organism. I think while there was hope initially that more brain imaging wasn't needed, it certainly is needed now. He needs an MRI to see if there's a focal mass lesion driving the infection, and the strep pneumo, right, with all bacteremia. The question is, where did it come from? Where did it go? To Zaven's point about kind of the limited sensitivity of some of the initial exam and diagnostics, I think now probably worth getting a better look at the lungs with the chest CT to see what's happening there. And then be aware what else strep pneumo can do. He's bacteremic. It can cause endocarditis. Those can cause, of course, septic emboli to the brain. But when you have the triad of strep pneumonia with endocarditis and meningitis, which we'll have to wonder if it spread to a CSF, that's sort of a syndrome that carries the eponym Austrian syndrome, but is basically an advanced disseminated strep pneumo syndrome that, again, he's a host who's at risk for. So the seizure, right, we would really say it's another sign of localizing pathology in the brain. So at this point, we really do need the MRI of the brain, pending what that shows, consideration of LP. And we really want to look at the heart valves now with an echocardiogram as well to see where has the strep pneumo gone. I would probably get cross-sectional imaging of the chest if it were available at this point too, to put together the whole story of where did this start and thus where has this spread to.
Steph, would you do an LP now too?
I think I would get the MRI first to see what's there, both because, right, is there a localizing mass lesion, or to see if it's sort of cardioembolic, kind of multiple vascular territory pattern. But pending that, consider the LP, because if he has meningitis, that's just going to change dosing, duration, even with kind of, I mean, endocarditis would buy him a long course anyway, but we'd really want to make sure we picked a CNS accessible dose of ceftriaxone, for example. So I would do MRI first.
Yeah. I'm thinking about what the relative frequencies are of strep pneumo endocarditis, which is quite rare but very aggressive and sort of would certainly fit in this situation versus meningitis. Um, and then I'm also just thinking again about kind of local susceptibility patterns because the patient hasn't really improved for in like 3-4 days on what you would think is appropriate therapy, which ceftriaxone absolutely is, right? But like the reason that the meningitis guidelines, the empiric treatment of meningitis, at least the US IDSI guidelines are ceftriaxone, um, acyclovir, listeria if you have risk factors, whatever. But then vancomycin, even if you haven't had neurosurgery recently, like what's up with the vancomycin, right? And it's actually not trying to cover MRSA. It's trying to cover what, at least in most places in the US, is only like a 1 to 3% rate of strep pneumo resistance to ceftriaxone. But like meningitis is such a severe syndrome that you don't want to take even that small possibility, right? So I would also wonder just locally what the strep pneumo resistance rates are, and if it's again anything below, or susceptibility rates are, and if it's anything below 98, 99%, again, you would just want to make sure that this particular pneumococcus is actually susceptible to the antibiotics we're using. But yeah, very, very sick patient. Obviously very, very worried about them, and tell us, Ashwarya, what happened next.
So next we did do an LP, and I don't think we did an MRI for this patient, maybe due to financial limitations. But we did go with the LP, and the LP showed WBCs were 800 with neutrophilic predominance, and the protein was 0.9 gram per liter, and glucose was 22. The PCR of the LP showed strep pneumo again, and the susceptibilities were it was penicillin and ceftriaxone resistant with levofloxacin susceptibility. Then we shifted the management. The ID recommended meningitis dose antibiotics with vancomycin that was renally adjusted. And the ceftriaxone was discontinued given the resistance profile, and steroids were deferred at this moment because of late presentation.
Wow. Um, this is not urosepsis. Um, how I mean, I have a lot of reflections, but Aishwarya, how did the patient do?
Was not there after the patient after my postings ended in the ICU, but I don't know what happened to the patient finally. I'm sorry.
Oh no, it's okay. And we can all hope he improved, but there's people die all the time of pneumonia, right? And people die of sepsis, and it's not because they're not treated appropriately with antibiotics. Like sometimes the infection wins, and I have some unfortunate like recency bias of just kind of people who are, have a lot of chronic comorbidity, um, uh, yeah, getting worse despite kind of best available treatment, and as part of why I was sort of primed to think about sort of the the family's kind of perspective and expectations, and anyway, but hopefully he did better, and in any case, I'm grateful for the opportunity to learn from him and from VAU Ashwarya. So thank you for presenting this case. Steph, what are your reflections?
Appreciate the kind of implicit teaching point you made, Aishwarya, about the role of steroids in bacterial meningitis. Correct me if I'm wrong for the whole group, but I think the data initially came from strep pneumo meningitis, and that was sort of the pathology where the clear benefit of early steroids came to fruition. But you made a really great point, Ashwara. This gentleman was now 5 or so days into his course. And so the benefit, right, and the acute hyperinflammatory phase was probably outweighed by some of the potential risks of that at this point. But, if we had had a signal earlier on of potential meningitis, up front, starting dexamethasone for him potentially could have kind of modified his severity or his outcome. So I just appreciate your teaching point about the timing and the benefit being there when it's early on. And strep pneumo is one of the organisms where it could have the biggest impact. Was the source thought to be, presumably he had pneumonia concurrently.
I was kind of analyzing my kind of pre-test weighings in the very early stages, just kind of thinking about like, how much reason is there to worry about a CNS infection? And I think the one thing that kind of gave me pause from the beginning, and in retrospect, definitely um, tell me, folks, if anybody knows or is able to kind of like pull up the actual data on this. But at some point, I remember learning that people with myeloma have a rate of pneumococcal infections that is like 1 to 200 fold the general population. So please correct me if you can find otherwise. But like, if you take that fact and this host into account, that suspicion of like, is this an extra CNS infection causing toxic metabolic encephalopathy versus this is a CNS infection, I think that kind of baseline pretest probability can and should shift dramatically, right? Um, and maybe in a patient like this, we should have had from the beginning, again, just a different degree of suspicion of potentially a CNS infection. Um, uh, because again, in all comers, like I would say that this turning out to be meningitis would have been much less likely, right? But again, in retrospect, seeing this the strep pneumo and again knowing about the myeloma, you just I feel like again, in retrospect, I should have had a different sort of weighing of those probabilities, but um, curious what everybody thinks about that.
Yeah, I think thinking about what the host may be enriched for, and early on thinking about vaccination history and asking about that in order to, right, see how high the risk is. So I think if we had maybe asked earlier about kind of bacterial particular vaccinations, or really any just vaccination history, that could have helped us maybe inform what he might have been at risk for. Do you know, Aishwarya, if he had been vaccinated against strep pneumo?
No, he wasn't
Yeah.
vaccinated for. It's not very
Mm,
prevalent. It's not very prevalent here, the vaccination drive.
mm,
Yeah.
mm.
Thank you. What a great case.
Um,
Were you going to add something, Zavin? Sorry.
no, please go ahead.
Yeah, I was just going to say what I learned a lot, and very, very sick patient who was lucky to have you guys as his care team, and really appreciated learning from the case.
Thank you so much for this opportunity, and I enjoyed this discussion, and I gained like a very new perspective. And uh, your points on uh, doing the abdominal exam and the MRI really, I think I would keep that in mind as well. And thank you so much for all your points, Dr. Zaven and Dr. Stephanie.
Thank you, Ashwarya. Um, Julia, thanks for taking notes, and over to you to give us your recap.
Okay, thank you so much for this amazing case and for the discussion. So just to recap, we had this 74-year-old man who presented with altered mental status with this previous past medical history of multiple myeloma. And the first important thing is to understand the multiple myeloma, that is a plasma cell disorder that could affect a lot of including CNS bones and so on, like for altered mental status. So some of the common non-misdiagnoses of it are sugar, hypoglycemia, CT, ABG, and narcotics. In this case, the fever and imbalance points toward an infection going on, and it's important to identify the source to act. And in this case, it's important to differentiate between intrinsic versus extrinsic process going on within the brain. So it's important to look at the baseline of the patient, if this patient was young or elderly, to look for the focality on the physical exam. If focal, this is more likely to be an intrinsic problem. In this case, the right case deviation could be an indication of a more focality and intrinsic process. As other than that, altered mental status associated with hypertension, as in this case, could indicate neurological emergencies such as subarachnoid hemorrhage, causing catecholamine storm, or high output heart failure caused by thyroid. And AKI, that inflammatory state likely infectious, and the lactate itself, it's caused by adrenergic drive or sympathetic activation, but can not be increased at first. Going on, this patient had a urinalysis that indicated maybe a urosepsis process going on. So in this case, it's important to start empiric treatment with antibiotics, and considering starting with broad spectrum such as carbapenem due to high risk of resistance. This patient on day 4 of hospitalization had this new onset seizure. So in those patients with a new neurological process, it is important to repeat the brain image and also followed by a lumbar puncture. We had a blood culture revealing the strep pneumo in this patient. So when the patient had a blood culture with strep pneumo, it's important to look for risk factors which this patient had. Common infections of this bug, such as endocarditis, pneumonia, or meningitis, and check if the bug is susceptible to the antibiotics that we are given. So in this case, it's very low chance of resistance to ceftriaxone, but that was the exact case here. And to end, the corticosteroids that had a very benefit when administered early in the disease course, especially for strep pneumo. So thank you, everyone.
Thank you, Julia. That was awesome. Thanks again, Aishwarya. Everybody helping out, everybody participating and teaching. Learned a lot and enjoyed it. Hope y'all have a great day.
Thanks, everyone. Bye.